So we'll get into the CBCT interpretation. When I've seen over the years, I've worked with a lot of different software programs, and over the years I've seen this happen a lot, where doctors, when I come in and we're looking at a case, and I see them treatment planning only off of the 3D model, which really makes sense. The 3D model, it's intuitive. You can see exactly where you want to place something. You don't have to, there's no learning curve to understand cross-sectional views or axial views. It's just really intuitive to be able to place an implant that way. But the reason that we don't use that exclusively is because of volumetric segmentation. When you get a DICOM scan and we put it into the software, we reconstruct a model from that DICOM. And when we do the model, create the 3D model, it's set on a threshold using Hounsfield units. And the Hounsfield units represent the level of density. So the higher the number, the higher the density. The lower the number, the lower the density. So if we pick a number that's high on that threshold, then it's going to discard any densities that are lower than that particular number. So as you see this image, you'll notice as we're moving that threshold up and down the scale, as we get higher, you start to lose bone. You lose the condyle, you lose the coronal process. You start to lose basic anatomy that you need to see. And then if we go too low on the scale, we're going to start to bring in soft tissue, and it'll give the appearance of bone. So when you're treatment planning off of a 3D model only, soft bone can actually look like no bone. It can look like there's holes in the bone. So it's important, but I don't want to discard the 3D model. The 3D model is great if, mainly for purposes. If you're placing an implant, you can see the trajectory of the implant coming through the restorative space really clearly on the 3D view. You can also, if you're determining parallelism between two or more implants, the 3D view is great for that. So there's a lot of very useful tools for the 3D view. But you don't want to use it exclusively, especially when you're looking at the surgical aspect of treatment planning. And when we look at the surgical aspect of treatment planning, the two views that I use the most is the axial view and the volumetric slices, or the cross-sectional views that I spoke about earlier. So the way that volumetric slicing works is you'll see here there's a stack of letters, and they're slightly transparent, representing a 2D film. You can see A really clearly. You can see B pretty clear, but C and D kind of disappear behind that because it's behind the other anatomy, and so we can't see it as well. And the bone beam is that we're able to navigate through the data much differently than we can on a 2D. And I like to compare it to a loaf of bread. So on a loaf of bread, we can slice it at any thickness. We can do 1 inch thick, we can do a ½ inch thick, and we create all of these slices. With cone beam or volumetric slices, our typical standard is 1 millimeter thick cut slice. So we're going to slice that original stack, and you'll see here we sliced it, and we're pulling out the C behind there. And then we do that for all the other layers there, and then we lay it flat. So you can see A, B, C, and D really clearly now, instead of having them stacked on top of each other. And this volumetric slicing is great to see the buccolingual width and the vertical height, and also comparison to maybe the nerve or other anatomical areas. So let me show you an actual example of cross-sectional views. This is a bite ring. You'll see that on that molar there is, on the mesial root, a 45-degree angle. The distal root is going straight through the canal. You can see the superior and inferior cortical outline of the canal, and the tooth, or the root there looks like it's going straight through it. So we have a CT. We took a CT, and the top layer is a pano. It's a 12 millimeter thick cut pan. So we're seeing all of the anatomy on the mandibular arch right there. And you'll notice that tick 145 at the bottom, we're going to follow that line all the way up. And you'll notice that that slices straight through that distal root. So we're, just like the loaf of bread, we're going to pull that slice out and lay it flat. And that's what we're seeing here. You'll notice the red marker is marking the superior aspect of the canal, and we can see that in a dot. And then also the tooth root doesn't go through the canal. It's actually sitting clear to the lingual by several millimeters, it looks like. So this is just how we navigate through the cross-sectional views as we're placing implants. As you can see, the buccolingual plate is really clear. The vertical height is easy to see, and we could take measurements directly on that as well.